Hi, this is Brian Kim. I'm going to share with you episode number 1 in the From Good to Great series. And this is going to be a video on how to ensure a watertight seal of your cataract surgery main incision. I'm going to share with you my stepwise approach on how I seal the main incision, where I place the cannula, how I place it, how much fluid pressure I apply, and the rationale and the technique. First, you want to hydrate the edges of the incision. And then once you get this focal area of edema, you can use that point to hydrate the roof of the incision. And then you want to inflate the anterior chamber, and that anterior chamber elevation of pressure will seal the floor of the incision. And then you finally check the wound to make sure it's dry. A lot of people will use Waxel sponges or they'll use fluorescein strips. All of those things are actually quite costly. And I just use a cotton tip applicator. And when you apply that cotton tip applicator, you will see a silvery sheen with the light reflection from the microscope light. So here's the first case. I always push BSS when I pull out that INA handpiece to make sure that the anterior chamber is nice and formed. But you can see I have a really nice square incision here. So this is the first step. I'm going to hydrate the edge of the incision. You want to make sure the fluid stream is near perpendicular to the edge of the incision. And then you want to push it into the mid-anterior stroma, okay? Not too posterior, more anterior actually. And you want to cause hydration of that area, but you don't want to be too aggressive. You want to just get focal area of whitening in that area, because pushing more just causes more stromal edema away from the incision, and it doesn't really make any sense to cause that whitening. It's just going to actually interfere with the patient's visual recovery because there's so much edema that needs to be dehydrated by the corneal endothelial cells. So just cause a focal area of edema. And how do you do that? You want to get a nice plugging of the tip of the cannula into the wall of the incision, again on the edge side. That's why you have to be perpendicular, and then just a nice gentle fluid pressure, and that will cause a focal area of edema. Again, you can see I have the cannula near perpendicular, plugging the cannula tip, pushing it against the edge of the incision, and again, not with overly aggressive fluid pressure, just with a little bit of fluid pressure, you're going to see a nice focal area of whitening. So same thing on the other side. Again, near perpendicular, you want to occlude the tip into the wall and the edge of the incision. And once you have that occlusion, you can get a nice focal area of edema. Sometimes I'll see people, they're pushing the fluid even before they get occlusion. And that doesn't make any sense. Get good occlusion and then push, and you'll be able to see you have nice focal area of edema. You can see I'm not too posterior. If I'm too posterior, as I'm showing with the arrow, and I place that cannula back there, you won't get a good seal because the internal aspect of the incision is right there. As far as hydrating the roof, you want to hydrate from the edematous edge that you started from. You have this area of edema that's coming down from the roof. You want to stab the cannula right into that area, rotate the cannula more perpendicular to the roof line, tilt the tip upward towards the microscopes. You want to tilt upward, and then you start pushing for a focal area of hydration, and you want to follow the roof line all the way side to side, side to side. As you do that, you should see a focal area of whitening in the roof line of the incision, but you don't want to, again, hydrate too posterior into the internal aspect of the incision. So as that's what you're seeing right here, I was able to do that fairly quickly because I was just going through the normal steps of my surgery, but you can see that nice whitening along the roof line. I go ahead and hydrate my side port incisions now. I'm making sure that the lens is perfectly centered as I come out. That intraocular pressure will help seal the incision. And then finally, I'm using a cotton tip applicator to check the incision. And you can see that nice silver reflection of the incision right there. That means it's nice and dry. So let's show a quick cartoon. This is the side view, a cross-sectional view of the incision. Imagine I'm injecting the edge of the incision first on the right side, trying to stay near perpendicular, and I'm going to get this nice area of focal edema. I'm going to hydrate the left side incision again. I'm going to push that cannula near perpendicular, get good occlusion, and then I'm going to push to get that nice area of hydration. But then when I want to hydrate the roof, I have to start from that edematous edge point because you've already created that edema. Push that edema line all the way towards the roof line and just go across the roof line, staying along that plane. You're going to get nice hydration along the roof line. And then by pushing BSS into the anterior chamber, you're increasing intraocular pressure, and you cause the floor of the incision to be pushed upward and tamponaded and closing the incision. So this is a cool modification of the technique. After hydrating the second edge of the incision on the left side, you keep the cannula within the incision and just quickly pivot and hydrate the roof line. And so you're going to see that modified technique. This is a little bit more efficient. Of course, from an ergonomic standpoint, sometimes it's more difficult to do this, but you're going to see again, as I come out with the INA handpiece, I keep pushing BSS to prevent chamber collapse. I hydrate the right side, and then I hydrate the left side. And then this is what I'm going to do. I'm hydrating the left side, and then while it's hydrating, I'm going to rotate the cannula. You see that? I'm rotating the cannula and then hydrate the roof. That happened very quickly, so let's show that in a fraction speed here. I hydrate the edge, pivot within the incision, rotate along the roof line, keep pushing and hydrating, and you get nice whitening and hydration of the roof. Go ahead and hydrate the paracentesis incisions now, pushing BSS to make sure that the intraocular pressure is up. This causes the floor of the incision to come up and tamponade that incision closed. And you can see as I dry with a cotton tip, you get that silvery edge. So what if it's still leaky despite those maneuvers? Well, sometimes you just have to repeat the maneuvers. And sometimes maybe you thought you did good hydration, but you didn't. Maybe there was an area that wasn't quite hydrated. And you're going to see that right here because I'm going to have to do the technique twice. So again, pushing BSS with the cannula as I come out with the INA, hydrate the right, hydrate the left edge, hydrating the roof. You can see the whitening, but you see it's pretty good, but you see there's a little bit of central area that I didn't get complete whitening, and I just missed that in that moment. But you can see there's a small little vertical sliver that was more gray, not totally whitened. And so I'm going to hydrate my paracentesis incisions. I push BSS, making sure that the intraocular pressure is good. But as I check my incision, I notice that it's leaky. So what do? Just go back and repeat the maneuvers, hydrate the edge, and then I'm hydrating the roof. But again here, look at the central part of the roof. It's still not completely whitened. You see that? So now here, I'm going to go in with the roof again, and I'm really intentional right there in the middle. I finally get whitening of the central roof, which I didn't before. The pressure is pretty high now. Release some pressure, and then now look. Nice and sealed. You can see it's that silver edge is there now. So what if you have a leaky incision despite all your best efforts? Sometimes you have to wave the white flag and just go ahead and place a suture. There's nothing wrong with placing a suture. Sometimes you think, well, if the architecture of the incision is good, there's no reason for it to not seal. And I agree with that. However, sometimes, it happens and you have to move on. You can't stop and just keep hydrating forever. Just go ahead and place a tenonylon suture and then be done with it. As I take the INA handpiece out, I push BSS in. I go ahead and hydrate the edges, first on the right side and then the left side, and then I hydrate the roof here. Again, following all the techniques that I just talked about. Go ahead and hydrate the paracentesis incisions now. I always like to hydrate the roof as well on the left side here because I have a lot more manipulation of my left side incision. So I not only hydrate the edge, but I also hydrate the roof of my paracentesis incision. My right side incision, not so much. I don't have as much manipulation. I just hydrate the side. And so as I finish up here, I'm checking the wound and it's still leaky. You can see that there's fluid there. So I say, okay, I'm going to just go do it again. So I'm getting nice focal hydration right at the anterior edge, following it along the roof line, and then on the other side. I feel very confident that this should seal. You can see nice whitening. I stayed nice and anterior. So in theory, the roof should be collapsed and pushing down on the incision, but you can see here, it's still leaking. You're not seeing that silver reflection. And as I'm touching it with a cotton tip, I can see there's fluid there. So I start on the other side now, on the right side, get nice edge hydration, and then I'm going around the other way, hydrating the roof and then hydrating the left side edge. Pushing more BSS in, trying to lock in the incision, but it's still leaking. So again, I know that I have a good incision. I had good architecture of the incision, but sometimes, the eye doesn't care about the architecture of your incision and it still leaks. And so I go ahead, try one more time. My staff are looking at me and they're going towards the cabinet to pull the suture. And I said, let me try one more time here. Obviously, the more and more you hydrate, the more diffuse the hydration becomes, and you're starting to get infiltration of the edema into the central visual axis, which you don't really want. But you can see here it's still leaking. So I've hydrated multiple times now, and obviously this is where you say, okay, let's go ahead and pull the 10-0 nylon suture. No reason to just continue to do the same thing over and over again, because doing the same thing over and over again and expecting something different is the definition of insanity. So we go ahead and place a 10-0 nylon suture. Of course, now the incision will be nice and watertight. So again, number one, hydrate the edges, get nice occlusion of the cannula tip, stay near perpendicular, apply gentle fluid pressure to cause focal area of hydration. There's no reason to cause this huge diffuse area of hydration. Do the same thing on the other side. Use that area of edema to point the cannula tip in as you follow the roof line, and you want to cause focal area of edema along the roof line. Again, you want to be more anterior, right? You want to be more peripheral when you're making the incision so that you have enough of that roof line edema to tamponade along the floor of the incision. You want to increase intraocular pressure. That causes the floor to come up, and then it compresses the wound, and then you have a nice seal. You saw my modification where we start on the left side edge, and as you're causing the hydration, you rotate the cannula 90 degrees, and you go ahead and start hydrating the roof line. Nice and efficient, real kind of a nifty way to do that. And then at the very end, you place a cotton tip on the incision, and you should see that nice reflection from that dryness of the incision off the microscope light. And again, you don't have to use wax cells or fluorescein strips with this technique. And again, if you have a leaky incision, hydrate again. But then if it doesn't work, don't be afraid to place a 10-0 nylon suture. You want to have peace of mind that the eye is nice and stable when the patient goes home. You don't know if they're going to rub their eye. You have no idea what's going to happen when they're away from the OR. So you want to provide a nice, stable situation for the patient for the best result. These are my tips on how you can achieve a nice self-sealing incision. So I hope this was helpful to you, and I thank you for your attention.